Welcome to another Justice Saturday. I am Alice Faryna, representing the Healthcare Focus Group of the Justice Action Ministry at the First Unitarian Universalist Church of Columbus. My topic today is healthcare in the context of a pandemic. I am a retired physician, survivor of private practice, neighborhood health centers, academic medicine, and the VA. Ending my career as medical director for Part B in Medicare in Ohio and West Virginia. I had enjoyed the practice of medicine until the 1980s, when doctors were assaulted by new organizations intending to reduce healthcare costs, managed care organizations, healthcare maintenance organizations, preferred provider networks, none of which I understood. I did not handle the billing. I focused on clinical care. Then I noticed that some of my patients would disappear without warning. A few years later, some came back, explaining that under their employer plans, I had not been a preferred provider and they could not afford to see me. When I again became a preferred provider, they came back. Now, how's that for continuity of care? Medicare taught me that government can do some things right. It introduced many efficiencies, which private insurance companies later adopted, by the way. A uniform fee schedule, a uniform claim form, a computer program designed to detect fraud, and a system of peer-reviewed research to determine what new technologies and treatments offered a proven benefit for coverage, with no costs for marketing, no multi-million-dollar salaries or golden parachutes. This is what led me to the Single Payer Action Network of Ohio when I retired. I'm going to share some slides with you now, so give me a moment. To get into the slideshow. Single payer simply means that one fund administered by a nonprofit government agency would make payment for all necessary medical services. All, period. The 1,500 private health insurance companies that currently do this work, each raking in profits for its stakeholders and each with its own expensive bureaucracy and complicated policies, would no longer be involved as middlemen. Medicare is an example of a single payer plan. That is why SPAN and other single payer states have adopted the terminology improved Medicare for all. While other industrial nations around the planet have been steadily moving into universal coverage since the 19th century, the United States has been stuck in a dysfunctional approach that makes us an outlier in terms of per capita costs, despite still having over 20 million people uninsured. The yellow bar at the bottom is our public expenditures alone, and with the exception of Switzerland, exceeds the per capita costs of all other industrialized nations. And then the orange portion of the bar represents the added costs from the private sector. The private corporations defending this costly healthcare system oppose Medicare for all, saying it would rob people of choice. So I ask you, which choice is more important to you? Choice of your insurance plan or free choice of the physicians and hospitals that provide your care? Let's take a look at how we got here. Back in 1912, President Teddy Roosevelt, noting the recent advances in Germany, ran on a universal healthcare platform, but was defeated. 20 years later, his cousin Franklin was elected during the Depression. Although FDR did try to introduce a healthcare program, all he was able to get through Congress, a hostile Congress, was a Social Security program. That alone lifted millions of seniors out of poverty. His successor, Harry Truman, tried again in 1947 and failed. A breakthrough occurred in 1965 when Lyndon Johnson signed into law the Medicare and Medicaid bill, protecting even more seniors from poverty. 18 years went by. Bill Clinton put his wife in charge of putting together a healthcare program, but that too failed, killed by Mitch McConnell. Recognize that name? Finally, in 2008, the Obama administration was able to squeak through the Affordable Care Act, but had to drop the public option. The number of uninsured decreased through expansion of Medicaid and making a variety of plans available for those who did not qualify for Medicaid. However, it actually added to the administrative costs of private insurance by creating exchanges that people had to use. There were several good features, however, including expanding free coverage of preventive services and protecting those with pre-existing conditions from losing their insurance. Unfortunately, there's a deep partisan divide on this topic. Conservatives firmly support preserving a for-profit insurance system with no constraints on monopolies. The pharmaceutical industry is a prime example. More is spent on marketing and administration, the red portion of this pie chart, than they spend on research and development or even manufacturing. And with no controls on pricing, their profits are among the highest among the Fortune 500 companies. Hospitals, another monopoly, are now mostly privatized. They currently bill per item and service, greatly inflating the price of each aspirin and each Band-Aid because they can. And even the nonprofit hospitals show an excess of income, which, in my view, must represent profits. Why not reduce this waste? The average physician spends almost a day on paperwork. Dealing with denied claims and begging for pre-authorizations. Well, we can reduce this waste by negotiating for drug prices, which other countries do, and even our own Veterans Administration is allowed to do, but Medicare and private plans may not. We could establish global budgets for a hospital based on estimated annual costs and pay them a monthly stipend, which would save billions of dollars. And we could simplify billing procedures for providers. If we expand coverage to all those currently uninsured and eliminate co-pays and deductibles, there will be more spending, right? Well, yes. And more taxes, right? This is socialism, if not communism, resulting in your loss of freedom and would bankrupt the country, right? Well, first of all, provision of health care will remain in the private sector, which refutes the socialism charge. As to bankrupting the country, that's where our current pathway is headed. Let's look at the numbers. SPAN commissioned an economic analysis of a state plan for Ohio modeled on Medicare. It shows that savings can be seen in all sectors of costs. The blue portion of the chart is the reduction, the savings achieved by reducing provider administration. The large orange section are the combined savings from getting rid of monopoly pricings in hospitals and pharmaceuticals. And even the Hospital Insurance Administration would be reduced by $9 billion. So how will we pay for all of this? Most of the money will come from existing funds folded into the new system, from Medicare, Medicaid, Children's Health Insurance Program, the Military Retirees TRICARE, and Affordable Care Act subsidies. The analysis showed there would be $40 billion more needed to cover this expansion. Oh no, you say, we can't do that. Taxes are always very bad. Well, are they? There are some very bad trends already going on under the current system. This slide shows the steady rise in deductibles, which is the orange line at the top, and the steady rise in family plan premiums, which is the green line just below that. These are rising faster than wages. Employers are doing a good job of shifting costs to you in the form of out-of-pocket costs, so that by 2019, the average family premium was over $20,000, with the employee paying $6,000 of that. The average single deductible was $1,655. Now, there are many different plans, and those with lower premiums have higher deductibles, and those with low deductibles have higher premiums. My daughter actually consulted a family member who has a master's degree in healthcare administration when she tried to make sense of the available private plans this year. How many of you have such resources? So what happens to household incomes under a public plan? This shows the savings in the Ohio plan adjusted for income level at the bottom. The income levels range from $20,000 to $150,000. And at each income level, it shows that current costs shown in the yellow bars are higher than costs under a public plan shown in the green bars. There are several models of different taxes that would be needed to make up the $40 billion needed to achieve universal comprehensive coverage in Ohio. I don't have time to go over the details. Here's the main takeaway, though. The current system is a form of regressive taxation with fixed premiums and deductibles, varying only by the type of plan you choose, not related to income. Taxes are progressive. They are a percentage of your income, so those in the lower income levels would pay less than those with higher incomes. The bottom line is you're going to pay for this out of one pocket or another. Which plan leaves some money in your pocket as disposable income? A single payer plan. But all these numbers are from 2019 or earlier. Something happened in 2020, right? COVID. Suddenly, the US was hit with unemployment levels last seen in the Depression of the 1930s, peaking in April at about 22% and now gradually declining. But the future is unpredictable. Between February and May of 2020, 5.4 million Americans lost health insurance, and that includes 139,000 Ohioans. The hopes of an effective vaccine being available this year are not founded on reliable data. So we really can't be sure what's going to happen next year. But the hospitalizations caused by COVID are massive and costly in both dollars and lives. We are told there may be another resurgence, sometimes called a twindemic. Right now, the projections are that the unemployment rate will continue to fall through 2021 if all we have to deal with is COVID. That's represented by the blue bars. But if we get a large outbreak of influenza on top of COVID, then the black bars represent what we might see in the way of unemployment. This crisis has showed us the flaws in an employer-based health insurance system. The director of research at the Economic Policy Institute recently said, delinking health insurance from jobs should be a top policy priority. He ended with a plug for Medicare for all. Imagine the relief of not having to choose between paying your health insurance premium or paying your rent, between buying medicine or buying food, and not having to worry about going bankrupt from a hospital stay, an emergency room visit, or a surprise bill from an out-of-network provider. Say goodbye to the maze of so-called choices. When your family needs health care, you simply go to any hospital or doctor in the entire United States, and it's covered. No copays, no deductibles, no coinsurance. That's what Medicare for all is about. Join us. Become an activist. Visit the websites on this slide and find ways to engage. Our strategy is two-pronged. At the state level, there is legislation which would replace our current multiple payers program into a consolidated, publicly funded single-payer state plan. Nationally, bills have also been introduced in the House and Senate for a national plan. We don't care which is achieved first. Either will be a victory for the millions who cannot afford health care now. Remember the words of Winston Churchill. You can always count on Americans to do the right thing after they've tried everything else. Thank you for listening. And let's get to work on getting universal health care coverage.